The famous 5 of choroid. In this video, we demonstrate the ophthalmoscopic and imaging characteristics of choroidal hemangioma, osteoma, granuloma, melanoma, and choroidal metastasis. Choroidal hemangioma is a hematomatous lesion which may be circumscribed or diffuse, may be isolated, or may occur in association with the Sturge-Weber syndrome and presents as a well-defined orange-red colored mass posterior to the equator with a diameter to height ratio of more than 2. However, the diffuse variant involves more than one quadrant showing a characteristic splashed ketchup appearance. A B scan with an A scan cross-vector shows a typical dome-shaped lesion with high internal reflectivity and acoustic solidity similar to the surrounding choroid in a circumscribed choroidal hemangioma. A fundus fluorescein angiogram demonstrates a hyperfluorescence in all the phases, while an indocyanine green angiography demonstrates a hyperfluorescence in the early phase with relative hypofluorescence in the later phases, referred to as the washout phenomena typically seen in a choroidal hemangioma. OCT angiogram through the lesion demonstrates a dense, irregular vascular network in the deeper choroidal layers, which appears larger than the surrounding normal choroidal vessels. Choroidal osteoma is a rare benign ossifying tumor characterized by a mature cancellous bone involving the choroid. On examination, it presents as an orange-red to a pinkish-orange lesion with a distinct geographic or scalloped borders with branching vessels on the surface of the tumor in the juxtapapillary and macular areas. Fundus fluorescein angiogram demonstrates a patchy hyperfluorescence in the early phases with staining in the late phase. OCT angiography is important to rule out the presence of a choroidal neovascular network in a choroidal osteoma. Choroidal granuloma presents as an intense or a dull yellow, elevated choroidal lesion with or without a surrounding subretinal fluid and may be single or multiple, with an associated vitritis. Ultrasonography demonstrates the presence of a dome-shaped mass with medium to high internal reflectivity with an angiogram demonstrating a hyperfluorescence in all the phases pointing towards the etiology of the lesion. Choroidal melanoma is the most common primary intraocular malignancy and overall the second most common intraocular malignancy in the adults. It may present as a nodular or a mushroom-shaped pigmented lesion with presence of orange-colored pigment over the surface of the lesion and subretinal fluid. Ultrasonography with A-scan cross-vector shows choroidal excavation with a high surface to low internal reflectivity referred to as the acoustic halo and a characteristic orbital shadowing. Fundus fluorescein angiogram demonstrates a blocked fluorescence with extensive leak or pinpoint leak at the level of the retinal pigment epithelium, while autofluorescence shows clumps of hyperautofluorescence. CT angiogram demonstrates a serous retinal attachment with an increased blood flow through the lesion. Choroidal metastasis is the most common intraocular malignancy. It presents as a creamy yellow, plaque or plateau-shaped lesions posterior to the equator with a lower height to base ratio, disproportionate amount of SRF, and often carry the characteristics of their primary malignancy. Ultrasonography demonstrates a slightly elevated subretinal echodense mass with a high internal reflectivity. A fundus fluorescein angiogram shows a hypofluorescent pattern in the early arterial phase with hyperfluorescence in the late venous phases and pinpoint leakage at the border of the tumor. An OCT and an OCT angiogram shows the characteristic lumpy bumpy appearance of the choroid with compression of the anterior choroidal vessels with an increased flow through the lesion. To conclude, thus, in a busy ocular oncology clinic, it is imperative to distinguish these choroidal lesions both clinically and with the aid of multimodal imaging, which may be likened to a drop in the ocean, but without which the ocean remains incomplete.